All right. Welcome, everyone. We're super excited for the fourth installation of Health AI for Dummies, a monthly podcast exploring Gen AI in healthcare and what are the current applications, what are the policy issues, and what are the ethical issues. We're super excited today to welcome two different guests. Let me actually tee up the topic of today's episode, and then we're going to actually have each of our guests introduce themselves. Today, we are focused on the clinical applications of Gen AI in healthcare. There's been an explosion in the healthcare industry of people investing and doing sort of POCs and pilots in this space. We're in the early innings, but we're seeing a lot of traction. Today, we really want to talk about, are we ready for clinical applications? Is Gen AI ready to be put into the clinical workflow? Or should we still be thinking about ways to keep it in the back office around automation and efficiency? I can't think of two better guests today to help us go through that kind of debate. Let's start with Tina. Tina, you've got a very well-known background. You're at a very well-known company right now. Tell us a little bit about yourself and how you've arrived at Abridge.
Absolutely, Missy. So I am the Chief Clinical Officer of Abridge, and I'm also a practicing pulmonary and critical care doc. And my story starts like many doctors, which is that I got burnt out. And thankfully I stayed in, largely because of my family. I'll just share, since we're close buddies on this podcast. My brother told me to man up and stay in medicine, so I did. But it put me on this journey where I've now been working on how do we redesign the workplace, thinking all the way from the top with the policy all the way down to what it feels like when you practice every day, so that our healers actually can stay in the profession. My journey's been pretty interesting. I've worked at the highest levels, and I'm privileged to say in 22, I was senior advisor to our current U.S. Surgeon General, Dr. Vivek Murthy, where I spearheaded his initiative to address health worker burnout, resulting in an advisory from the Surgeon General's office, which is actually the blueprint for the country on how we address burnout across all the health professions. And it's being played out right now. And even prior to that, had another tour in federal government where I had a dual appointment in the White House. In this case, I served in both the Obama and Trump administrations and served in VA as the first National Director of Clinician Wellbeing for one of the largest health systems in the US. Along the way, continued to practice, got burnt out, got unburnt out, started to fall in love with technology. And that's actually where my story comes to a bridge, which is that I truly believe that it's time that the tech works for the humans, not the other way around. And I found a company that's doing just that.
Amazing background. And I love that you're so mission-based and that you've literally lived the burnout. My father is a practicing nephrologist at 81, has been in private practice in Southern California for, 40 plus years, and is just so ready to sort of see a new model of administrative caregiving. So John, let's go to you. You and I met probably a year and a half ago when you were sort of on this new journey for company creation. I was at Redesign. We were doing a lot of company creation and ideation all the way to commercialization. And I was so tickled pink to see that you were setting up a new model. Tell us a little bit about your background and what you're doing at Aegis Ventures.
Perfect. Well, it's hard to follow Tina's introduction, but I will do my best. So I'm co-founder and managing partner of Aegis Ventures. Aegis is a company creation platform. So we're basically a company that builds companies. My background prior to starting Aegis was as a private equity investor. I joined our sister company, APL Group, which is a global private equity firm, around 7 years now, was very focused on a lot of our entrepreneurial initiatives. And so was building new business lines, new platforms, working very closely with the founder and chairman. The way I ended up getting into healthcare and my baseline level of interest really came from my mom, who was a nurse, got very sick when I was young, saw her struggle to access the healthcare system for really my entire life, studied public policy with a big focus on healthcare at Harvard, also spent a lot of time doing the same thing in graduate school. So it's always been a significant level of interest in the field, wanted to build a baseline level of investor skills through working in investment banking and private equity. But the goal was always to do something in healthcare. Started doing a lot of minority VC investing through a partnership we formed with Northwell Health back when I was at APL. And from there, just saw enormous opportunity given all the advances we were seeing in AI around the time to be able to partner closely with the largest healthcare systems in the US, starting with their problems, working backwards, in approaching it very flexibly, whether that means building a team from the ground up, buying technology that we can build on top of, or building around an amazing scientist. And we still employ those couple of different approaches today. Have built 5 companies, primarily with Northwell over the last 2.5 years. The model has worked really well. Goal was always to create a blueprint and a playbook for how we could help health systems all across the country, to re-engineer the experience of healthcare for both their patients and their clinicians, starting in this, very in-depth co-development mode of working really closely with the frontline clinicians and administrators who are using these tools every day. And so we've now launched what we're calling the Digital Consortium, which is a group of 9, soon to be 10 hospital systems all around the country. All are leaders in, clinical quality, size, appetite, and capacity for innovation, and willingness to co-develop and deploy and invest in new technology. So we're really scaling up our efforts now, trying to get to a place where we can build 5 or so companies a year. Still pretty concentrated in our approach, not as many as Redesign Missy, but really trying to scale up and be able to scale the amount of impact we have in partnership with a larger group of health systems. So very exciting time for us in that regard.
Yeah, I'd love to dive more into the model. And I want to specifically loop back to you in a minute about the 2 companies that do have a very large Gen AI backbone, that being Obtain, which we just heard about on the imaging space, and then Ascertain, of course. So I love the naming convention here, by the way.
Yeah, and we have a couple of more that are really involved in Gen AI too. So happy to comment on those as well.
Well, we're going to have a lively discussion. Before we get into sort of clinical versus back office and automation and like foundation models, and like are they Grey's Anatomy, WebMD language models, or can they really do things? Let's just sort of set the record straight for all of our audiences. Tina, just tell us a little bit about Abridge, because I want to qualify you guys as both experts. So, look, I've been in healthcare. I'm 54. I've been in healthcare for like 37 years. And, I spent a lot of time in government as well. I was at the first ONC with David Brailer. So we did all the meaningful use. So I was very familiar with the EHR world. And medical scribing has been around for a really long time. I did a tour at Amazon. We were on the Alexa Health side of the house for a little while. Really looked at sort of taking medical scribing forward by being able to listen to the doctor and patient encounter, create a transcript, and then automatically put that into a SOAP note and think about actions. That was like 10 years ago, and now we're finally at this point where we can do it. So tell me, what is Abridge? How is Abridge sort of taking, old school medical scribing into this next level of Gen AI? Just so we know a little bit about how to qualify you for this conversation going forward.
Absolutely. And it might make sense to just say, here's how the technology has felt, because I've experienced this as a doctor.
Yeah.
So, first we started off with pencil and paper. Then we finally moved to, I'm going to call it I'll call it dictation, where you either just talked into a microphone and then that evolved and became an app. But you basically had to say everything, including punctuation. Like 54-year-old man, history of hypertension, history of high cholesterol, presenting with shortness of breath, comma, lightheadedness, comma, period, next line. Not really human speak. It's very technical speak. And then we sort of graduated to, well, let's do that into a place where someone else transcribes it and it comes back, or it's someone doing it in real time and then it comes back and we review. And now we're in a whole different scenario with generative AI, because now we have the technology to instantly listen, but instead of regurgitate, this is about summarization. So we switched from, and we don't even technically really like to use the phrase scribe, only because sometimes people get confused. We're truly transforming and going from the classical, what I say is what comes out on paper. So what that means is I have to organize my thoughts in doctor speak, and we have a very rigid templated way that we summarize how we've seen a patient and what to do next for their care, to being able to talk in a normal way with a patient. And perhaps they start talking about their mother, and then they start talking about a TV show, and sprinkled in there, they talk to me about their shortness of breath. And then I go on a tangent, and that's how normal conversations go. And yet somehow this technology has the capability to summarize, to chop out what isn't really relevant for the medical note, to keep what is, but then summarize it and structure it into the exact places we need. So we're an AI native company. We actually made a decision early on to own our tech stack and build our models. And I think that's really the foundation of how we can start with where we are and only go up. The ceiling is limitless, it feels like.
Oh, that is fascinating. I love that you said or gave the history from a doctor's point of view of where we started and where we are now, and really boiling this down for people that are new to Gen AI to a summarization exercise. And the intelligence is figuring out what's important and what's not to essentially create a SOAP note and pre-populate it and a bunch of other actions that we'll get into. A little bit about the company. You've been around for how long? I know you've taken roughly 200 million in venture, and just a couple stats there.
Yeah, that's right. So our company was founded in 2018, and I'm proud to say we're AI native and clinician native. So our CEO and co-founder is a practicing cardiologist, Shiv Rao, and we also have really, really deep benches on the AI side. And to go back, just to explain, Shiv, while he's a practicing cardiologist, also was an investor at UPMC and would invest in provider-facing tech. He also created a really cool collaboration with Carnegie Mellon, and it was a healthcare AI ML sort of pipeline where there was this collaboration. It's so interesting that started before this company came out, but we actually utilize that pipeline quite often now. And our chief technology officer, Zach Lipton, is one of the leading ML experts in the industry in healthcare.
Very well.
So we really started with this very heavy foundation, and I think it shows. And so now, we're, as you rightly stated, we've definitely raised quite a bit. We are really in the scaling mode of trying to get this in the hands of clinicians. And I'm happy to share if there's interest, but we're seeing hard outcomes and hard impact. So it's not just anecdotes, but clinicians are using this. We're at scale, and it's actually helping.
And you guys sell to health systems as well as like large medical groups, IPAs. Do you have a sort of a solo or an ambulatory channel as well?
Yeah, that's right. And we actually started our product more focused towards ambulatory physicians, because that's actually clinicians, rather, physicians, APPs, but really because that's where the hardest hit specialties were when we think about burnout and trying to stabilize the workforce. But yes, we actually do have a product that people can use as individuals if they're practicing clinicians. The magic, though, is really in the integration with EHRs. And so that's where, we tend to focus a little bit more on health systems, because at the end of the day, if I create this wonderful note, but I'm still expecting, if our company creates a wonderful note, but we're still expecting the clinician to do several more clicks to copy and paste, we haven't quite solved the problem. And that's where having a deep integration, and by the way, we have a unique partnership with Epic. That's one of our partners, although we're agnostic to EHR, helps us get rid of those extra clicks so clinicians can just be clinicians.
I love it. Oh, I love it. I'm not even a clinician, and every single time I go to a visit, I just went last week for an eye infection, which is why I'm wearing my glasses. I'm like constantly veering over, and I'm like, no, let me see that screen again. Wait, don't you have a macro? Like they're on the most annoying patient, right? They're like, did you work for Epic or have you worked for Krasner for a year? Anyways, John, tell us a little bit about, you said you've got more companies than the ones. What first of all, what was the Gen AI and or AI mandate in sort of forming the mantelpiece of company creation, and a little bit about the companies and like how you're what your thesis is around company development with Gen AI?
Sure. So I think as we founded Aegis, one of the insights we had very early on was that healthcare was going to be an industry where there was rapid technological progress driven by AI. And I think as we were looking at kind of the most recent generation of healthcare AI that came before large language models, starting in 2014, you had CovNets and computer vision, a lot of really clinical applications, mostly focused on diagnostics. There's been some real impact there, but I think what made that very challenging was the regulatory environment is really difficult. It can take many years to get approvals. Then you need to generate reimbursement. From there, you first need to sell to the hospital system, then convince the service line, then convince individual clinicians to use it. So there's a lot of different barriers to adoption and scale. And so most of the places you've seen wide scale impact there have been in things like radiology, where you're improving the efficiency of clinicians. Then you had IBM Watson, which I think made a lot of the same promises as the technology that we've seen today, but it very much overpromised and underdelivered since the tech wasn't ready yet. I think what made us really excited as we started Aegis almost exactly 4 years ago now was we were seeing really significant advancements in NLP in particular. No one really knew what a large language model was 4 years ago. But the first company we launched, interestingly, was we pulled a team out of Google that was leading their affective computing team, which is the team that focuses on building empathy and emotional responsiveness into at the time, NLP and other products. And after we pulled that team out, we ended up needing to go out and build, extraordinary amounts of experiments in 18 or 19 countries around the world. Google was always our kind of closest design partner in doing that. And so there we built all of these measurement toolkits for emotions, facial expressions, speech prosody, so all multimodal AI. From there, we were able to build prediction models using those of every application from customer service. Did a customer service call go well? Does someone based on a vocal burst have Parkinson's? And you can train those online using our developer toolkits, using your own annotated data sets. We even have them around silly applications like Maury Povich from his facial expression, whether someone is or is not the father. So being able to train your own models online, we've taken that and we've expanded it to doing things like voice-to-voice assistance, and lots of other applications. And so the first company, and we have our own foundation models that we've built, which are far smaller and more efficient than most of the LLMs you see because the expression embeddings are so deep and there's such an incredibly strong understanding of human emotion. So even the first company was really kind of a Gen AI company before we even knew what Gen AI was. From there, we've focused on building a number of platform companies that are synergistic with one another. And all the companies in our ecosystem are meant to be able to partner with one another and complement one another as we go to our health system partners. One of the things I think we've heard over and over again from the systems we work with is they don't want point solutions. So anything you need to do needs to replace a lot of different point solutions. I know Tina and Abridge are approaching this in the exact same way. Everyone wants platform technologies that can land and expand and cover a lot of different problems, single point of integration, and focus on solving a wide variety of different challenges they're facing. So the way we've tried to think of it is not going and building 30 companies, but building a much smaller number that focus on really high magnitude, deeply felt challenges. And so Ascertain, which you mentioned, is really our solution for back office automation using a proprietary AI agent framework. So there we're doing everything from discharge planning, prior authorization, pharmacy, supply chain, all using the same technology stack, seeing amazing outcomes. I'll give you an example of case management. There we've already seen, we partnered with a case management team at Northwell to co-develop this product. They were spending hours in many cases on a single discharge to LTAC and to SNF, and writing by hand on papers, faxing information in, sitting on the phone for hours. We've gotten that down to a couple of minutes, and it's working incredibly well. And so you're seeing kind of like order of magnitude level improvements on the administrative side, which we're very excited about. And we're expanding the number of products across the back office. Care we view as our front office complement to Ascertain, where there it's really all about the patient experience and every touch point the patient has with the health system. And so automated care journeys, personalized content, scheduling, bill pay, small LLMs to be able to answer questions and prep for procedures, for example. And so there we're really trying to partner with all the major investments they've made in digital front doors, MyChart, for example, et cetera, help unlock the full value of those investments and make them successful in meeting patients where they are. And the last one I'll mention is you mentioned Optane. Optane is much more classic computer vision. It's regulated. So there we're doing diagnostics at the point of care, hardware plus software. We've developed a really low cost fundus camera, which is portable, weighs 6 pounds. It's around 70% cheaper than the ones that are used in most ophthalmology offices. And so the focus there is on primary care and being able to, catch more, severe illnesses and chronic conditions at the point of care, and then be able to make referrals into the health system. to catch those things and treat them before they become, systemic diseases that can cause major problems for people. So for us, it's really been in our DNA since the beginning. The first year of the Northwell partnership was really just focused on building out a data lakehouse that enables us to have the access to data that you need to be able to build these things.
Yes.
And so just commenting very briefly on that, one of the things that we were most excited about with Northwell, just given the population they serve in New York, most diverse patient population in the world, given that they're in every borough of New York, Long Island, Westchester, et cetera. And so it tends to generalize really well when you're building these models, which has been exciting.
Yeah, I love that. I think the reason why you've had such a lift in company creation, particularly in this space, is that, it's very hard. And we'll loop back to your sort of platform comment too. I have lots of sort of opinions on that as well. But I think you've hit the nail on the head. Both of you have actually developed your own language models. There's a lot of other startups out there that I have on the show that are essentially, I call them Gen AI wrappers. That's my term, Missy's term only. But essentially what they're doing is they're using a foundation model like, a Cohere, an Anthropic, or, AI, and they're building workflow on top of it. And they have to pass those costs on to their customers. It's almost like having a CRM or a database, right? It's all in your cogs, you're passing it on. And so no one's sort of figured out what the pricing, and they say, oh, we're foundation model agnostic. The problem is that it's expensive because you're using a large foundation model. And you may not have the best accuracy and or reliability just given how large it is. So let's go back to this whole concept of small language models, right, that are task-based or that could be sort of highly specialized in a particular vocabulary, clinical vocabulary that is, and, versus the foundation models, whether they're open source like Maestro, Mistral, or commercial. Like, I think there's going to be tons and tons of more foundation models. I think where we're going to see a lot more interesting evolution is on the small language models. So Tina, back to you. Like, how did you all think about training data, ground truth data? And it's a big ordeal to take on building your own model. Clearly you had this relationship with, both UPMC and Carnegie. I'm seeing a pattern here where both of you guys have been able to broker relationships that could actually help you with data acquisition. Talk a little bit about that, Tina.
Yeah, absolutely. I think you have to start somewhere and you need to have a large enough data set to start. But where I would say our company is now is that we truly have a tech stack. We have several different LLMs. We have an LLM for transcription. We have an LLM for multilingual. We have an LLM for physical exam. And I think that's a key point. And maybe not exactly where we started with this conversation about thinking about, the open AIs of the world, but there's this extra piece that we don't exactly talk about that I really want to highlight. And it's not just where you start and what you're serving up and what LLM or LLMs it's based on. It's how quickly can you iterate?
Yes.
So if you don't own your tech stack and you are really relying on something that you don't have personal control, I think you really struggle. And that's where we start to see that the ceiling is a lot closer for those kind of companies. In contrast, at our company, and we have a very rigorous way, it's different levels of testing before we actually go to GA. But let's say we decide, this week we're revamping and revising how well we do on physical exam. We can actually test our existing LLM that's focused on physical exam and this new iterative model that we've created. We actually, our clinician founded, we have clinicians sprinkled throughout our entire hierarchy, and we have clinicians that are coders, we have clinicians all over the place. And so we do these blinded trials along with many other things. But the key point to me is that this is not, I have one black box and it is generating a SOAP note. There is so much more under the hood, and you really need to have that flexibility to be able to tweak. And that means you have to own your tech stack.
Mm-hmm. Yeah. And I would imagine it's not just the language models, but it's essentially all of the fine tuning, the real time learning, the new inputs in. It's all the tooling, the LLMOps tooling that goes into sort of model governance, model drift, all of it. So
yeah, that's right. And our company uses the industry standards when we're looking for model drift. We are hyper focused to, like everyone else, and starting to think, develop the strongest strategy possible to try and mitigate bias.
Yep.
But I think what's most important now is that we need to have very, very tight feedback loops and multiple different types. So one of the things that I think is pretty cool, and for the clinicians that are listening in, this is neat. Our technology allows a clinician to give feedback right then when the note is generated on that very note.
Yeah.
So yes, we need to talk about what data did you train on, and our approach will be to use de-identified data. But as we're iterating our models now, a lot of it has been heavily focused on direct feedback, which is gold.
Yeah,
that's just
it totally is. Yeah.
Yeah, the direct feedback is really critical. One thing we've seen as well, so almost everything we're doing is using AI agent frameworks as well. Foundation models are incredibly important, but as we all know, they're insufficient to execute a lot of the really complex workflows within healthcare. And so we tend to spend a lot of time on thinking through those frameworks and trying to structure them to be very flexible and user responsive. Since whenever something breaks down in the process, when you look at the most recent, generation of RPA technologies, I think where they really failed was they were brittle. And when they stopped working, you didn't know exactly where the process broke down. And I think now what's really exciting is when you see AI agents that are chattering effectively and executing really complex workflows, when one of them breaks in the process, you know exactly which agent it is, and you can focus on fixing it, which I think is, just a leap and bound, improvement over the most recent generation of the technology. And to do that, as Tina mentioned, being able to own your tech stack is incredibly important. And from a cost perspective, as you hit on, Missy, I think using open source models that are smaller and fine-tuned for your specific task as you're operating at scale, all your OpenAI build does not matter that much when you've rolled out to 1 or 2 sites. But when you're operating at the level of scale that Abridge is, for example, the compute cost really does add up after a while. And being able to own that tech stack, I think, can make you much more financially sustainable in the long term.
Yeah, 100% agree. I think we're all on the same page. There's lots of startups that sort of have been in the incumbent space of workflow, or they've had sort of AI analytics and are sort of trying to kind of put another layer on to either stay in the game and or forcibly and fast come up. So we'll sort of see how that all plays out. I want to talk a little bit about, John, you mentioned a couple really interesting use cases that are more patient engagement, patient facing. I love the discharge one, but let's talk a little bit about like what the future could be for clinical applications. Tina, I think about Abridge, summarization is sort of just bread and butter, right? Like where you guys started, and it's like pretty wicked technology to actually be able to tease out of a conversation a full structured note. But I think about clinical actions. Like if I'm a physician and I'm like, I have to do a lab order, I have to do a specialty referral, I'm doing an RX prescription, like I would love it if my agent would just know all of that coming out of the conversation and then pre-populate some of that work. If I'm just signing off, so actions is really interesting. I think, figuring out how to also do a post-visit summary note, like just all of these small things that kind of can happen in macros, but like still require some clicks. Where do you see a deeper kind of workflow happening where it's more of a lift for clinicians using the sort of summarization as a base? And then John, I want to come back to you specifically on some of the use cases that you talked about, because we're seeing a lot in patient education, patient engagement, patient nudging, coaching. We saw Thrive, the big OpenAI announcement, what they're going to be doing. This was stuff that I was trying to do with Alexa and Amazon like 5 years ago. So it's really interesting seeing it kind of.
Timing is everything, isn't it?
Timing's everything. I have like every Google, Amazon device in my house, probably have 40 of them, being someone who worked both at Google and Amazon. And, it just seems like, forgive me, my stock may go down, but it seems like an old technology now, right? It's like it was so novel when it came out just, 7 or 8 years ago. Anyways, so yeah, Tina, talk a little bit about what the future holds, right?
Well, Missy, I feel like you gave me a layup because some of what you said is already happening at Abridge. So I'm just going to cut to the chase. Bottom line up front, we already have patient visit summaries.
Oh, nice.
So the doctor swivels their chair, sees the soap note in all the soapiness way that we like to write, but there is at a human grade reading level a patient visit summary. And I'm going to be honest, and I'm going to, pick on myself because I don't want to put anyone else down, but I usually write get chest x-ray follow up in 2 weeks. And that's my summary for my patient because I'm running behind. I want to go to the next patient. I don't want them to be angry that I'm late. So I try my best, but you know what Abridge does? It says, here's what we discussed. It actually summarizes what we discussed
Nice.
because people forget. Patients actually forget the majority of what was said because they're human. So do doctors, by the way. And then we actually say, here are the medical terms, and we define the medical terms. So we would never say congestive heart failure and leave it at that. We actually explain what that is. And then we talk about what the next steps are. And I think that's gold. But to take it one more step, and this is where, we're weeks out from this, which is, again, it's great to have it, but if we're forcing the clinician to take additional steps to actually get that into the hands of the patient, it's not okay. We have to reduce the cognitive load and the extra clicks. So we're actually in the process of even integrating our patient visit summaries so that when the patient opens up their equivalent app, depending on what health system they go to, it comes in their app directly.
Nice.
But there's a magical moment that's happening too, by the way, which is that the patient and the clinician can actually talk about the summary while the patient's in the room, which means the patient could understand, they could even correct the doctor, and the plan could be even better before they leave. So that's mind-blowing.
In real time, the patient could receive, if they just had My Chart open on their phone, they literally could get their post-visit summary note and discuss it, or the doc could use it as a tool.
That's right. And present day, the way it's being used is that the doc can show it on the computer because it is coming up that fast.
That's amazing.
Right? Because it's generative AI. But it's written in normal language. The patient now is at a much, more level playing field to the doctor than ever before. But, as far as thinking about roadmap, I think you mentioned probably my top 5 list of the things that drive me crazy when I'm working. And that's exactly the structure of where the company is going. We are next up and something that we're heavily involved in. And again, this really goes back to how deeply do you integrate with pick your EHR vendor of choice. But we are working on pre-templating orders. So
nice.
when you tell me you're short of breath and I'm like, oh, I wonder if she has a pneumonia, we got to get a chest x-ray. We're talking and it is pre-populating. This is like where a very deep connection with your EHR vendor is mission critical.
Yes.
Because all of the order entries in the EHR, right? As a doctor, I'm actually not sure doctors are trained to even write scripts anymore by hand. I still remember how, but we will listen to the conversation. Then we will kind of get to chest x-ray. But there's that second piece of needing to associate a diagnosis with the chest x-ray.
Right.
So it is really complicated and it requires a very deep level of integration to pull the associated diagnosis. So we're going from conversation to clinical note, conversation to care management, and I sort of encapsulate the patient summary as part of that. So thinking about even enhancing those, like imagine we give a doctor a nudge because we've helped to summarize even the last 3 months of the notes that are there and what happened, and we nudge the doctor to say, you prescribed a new statin, a new medicine for their cholesterol. Did you recheck labs? Did you recheck their cholesterol? Like just a gentle nudge to bring that up because we're in a fee-for-service environment. We still have 15-minute visits and it's really hard to be prepared and to catch everything for the patient. And then as we go another level up and we start getting into what I think is really interesting is clinical documentation improvement.
Yes.
So on one side, I'm getting credit for everything I've been doing anyway, and I've never had that in my entire life. And it sure is nice. But it's also great because the doctor's note serves 3 masters, right? We talked about the patient, we talked about the clinician, but we haven't talked about John's world, revenue cycle, and thinking about how the clinical documentation improvement. Imagine if you have the diagnosis and all the associated meet criteria written right in.
Yeah.
Now, I'm a doctor. Doctor speak isn't quite MEAT, right? But that's exactly what revenue cycle needs. And I get those messages that sometimes feel menacing, but really they're just good intention to help me get credit for all the work I did to take care of that patient. And now AI is helping the doctor fill out a more complete and accurate note. And then when we go even higher, we can start to get into that realm that is going to be highly regulated. And ONC already kind of put out some regulations for decision support.
Yeah,
but
I saw that. Mm-hmm.
I think this is really cool because I'm one of those doctors that's leaning in. I recognize that I can't keep up with all the papers because it's not humanly possible. The amount of science that's coming out is so much that I would love to have at the point of care something that almost feels like, and I'm not sure if you all know this this company, but up to date is
I
like
was
our
just going to say, it's an agent that's up to date in your pocket, in your ear, being like, have you read this article? What about this drug? Right? Yeah.
That's right, but on steroids. So
Yeah.
maybe it actually takes into account all those nuances of my particular patient. And I can't wait for that because I'm going to be a super doctor. I'm going to get supercharged and just be better at my job than I've ever been before. So it's a time where
I got so excited I had to just kind of clip you at the end. I think that's
Yeah.
the nugget for it, for policy regulators and people that are sort of a little bit more naysay, like, oh my gosh, this is Skynet, we're all going to blow up the world, right? I think that this is about making current clinicians better, faster, and have more availability of literature and decision support at the point of care. So it's supercharging you. It's not a replacement. No one's trying to replace doctors. There are some sort of interesting startups that they're like, I'm going to create a nurse chatbot. And, I think that's fantastic. And there's an interesting digital front door for triage. There's some use cases there, but this is about a supercharge. We're all drinking the Kool-Aid, but there are a lot of, what I call the Skynetters out there that are like, oh, this is dangerous. And, there's going to be massive liability. There's a whole bunch of news around just even prior auth liability. We're seeing where prior auth is just taking off. So John, I want to go to you. Is it Carrie? How do you pronounce it? Carrie? Care. Oh, with an I.
It's just care with AI.
Got it. Care with AI. Silly me. You mentioned a little bit, and I saw a couple press releases on that recently. I know Ash was involved for a little while.
Yeah. She still is. Yeah, she's executive chair.
Love her, by the way. Just adore her.
She's the best.
Yeah. So tell us, that seems really interesting because that's very patient focused. Tell us a little bit more about future use cases, where the world is going that's highly clinical, and what that company is doing upright now.
Sure. So I think one of the really sad things about the last 15 to 20 years is health systems have invested literally billions of dollars into new technology, EHRs, CRMs, digital front doors, ERP systems, all of these different technologies that are supposed to make the healthcare system more easily accessible to patients. And in many ways, the healthcare system is more dizzying and difficult to navigate than ever, unfortunately. And so what we're really trying to do with Care is give every single patient a personal care concierge powered by AI that can help all of their interactions with the healthcare system. Everything from how do I schedule an appointment, how do I prepare for a procedure that I'm having, a care journey that automatically updates, provides them with content, wearables integration, the ability to take patient-reported data, to give them responses using these small language models that we've created for individual service lines. So it's really taking the entire patient experience and turbocharging it. And I think a big part of the reason, candidly, why you haven't seen that to date has been health systems are just not equipped to resource it, right? So anything you do, as Tina would tell you, that increases the amount of volume in a physician's in-basket is almost a non-starter when you go to health systems.
Wait, I got to interrupt you. It is a non-starter.
Yes. Not almost, right? Particularly with labor supplies where we're at. Yeah, 100%.
And as we all know, you can't get reimbursed. I know some health systems are starting to charge for MyChart messages, but that's not very popular either. And so it's not possible to get reimbursed for these patient engagement tools. And so anything you do needs to drive downstream revenue. It needs to drive a better experience. It needs to create stickiness and loyalty and improve outcomes. And that's how we really frame ourselves. And so, even 5 years ago, if you went with a lot of this technology, it would require a human being to intervene, right? And health systems are already dramatically understaffed. And a lot of this would need to be nurse care managers and resources that are in really short supply across health systems. I think what we're so excited about is you need to have protocols built into these. So if there are urgent circumstances that need to be triaged, that those things get flagged. But in 99% of cases, that's not what's happening. And so the ability to automate a lot of those patient interactions with the health system and take the same level of experience we've seen in lots of other industries and the consumers love in providing those into the healthcare system, that's really what Care is doing.
That's amazing. If you had a crystal ball and you kind of have this fantastic platform where you can do the research, look at the trends, and start ideating into sort of development and into commercialization. I mean, that's the sort of yummy playground that you're in. And I certainly enjoyed my time at Redesign doing that. Where do you think the future is going to lie for more clinical applications? I mean, I was kind of blown away about the Thrive announcement, and what it's very similar to some of the things that you guys are trying to accomplish with care. What are 4 or 5 more interesting use cases that we could probably expect to see in 4 to 5 years?
Great question. So I'm happy to start with some of those. I'm very interested in what Hippocratic AI is doing with AI avatars,
Mm-hmm.
especially for nurse care management, for example. I think that's going to be a really exciting application, particularly for low acuity type use cases to start. I also think health coaching, massive low hanging fruit. We're already starting to see a lot of that. Same thing with therapy and CBT, particularly for low acuity use cases. We've started to build some of that out. It's incredibly good. I mean, what I really like is the general theme of how do you take the best health coach, the best therapist, the best nurse care manager, and really create a software version of them that is universally accessible so that everyone has the opportunity to access them. And in many ways, from the preliminary research we've done, it can often be better. Those versions often provide better experiences than human beings, which is really exciting.
Higher empathy, I mean, just because you could train in empathy responses, right? And so you're seeing that could be more personalized to your sort of conditions. You have contextual responses, right, based on data that you're giving. Yeah, we did a lot of experimentation on Alexa, and when I was at Google, on even trying to come up with a contextual health search, which is tell me a little bit about yourself, and I will make your search so much more productive. Of course, that was back in the day when a lot of the privacy folks were like, no, Google's a big brother. You can't do that. But we did spend a lot of time looking at that. So I love that thinking. Anything else before we pass it to Tina that's kind of top of mind?
No, last thing I would just say is I think people always get a little bit freaked out whenever you're talking about creating avatars of human beings. But I think in most of these cases, as we all know, it can take, for example, 4 to 5 months to get a therapy appointment in a healthcare system. Most people have no access to nurse care managers to help them with their discharge planning and figuring out how to get to the next site of care and recover from procedures, et cetera, and no real access to do meaningful Q&A with clinicians, et cetera. So I think everywhere here you're expanding access, helping clinicians practice top of license, and ultimately giving them more time to spend with patients and provide empathetic care. That's what I'm most excited about. I really see no opportunity here for clinicians to be replaced in any way.
I mean, if you look at HealthTap, right, 10 years ago, what they were trying to do, Cora for healthcare Q&A. There's a new company out there called Rune that's also doing that again. I mean, we've seen so many incarnations of, I love Neil Kosla's company, Cure AI, just trying to essentially figure out how to take these low acuity, sort of really quick kind of triage, urgent care. I need something. And there's such huge access issues now in a post-COVID world. I mean, we're so frustrated. We're trying so hard to get in to see. People are more interested in doing 15, 20-minute telehealth visits just to get the low acuity through. But it's really challenging in a lot of different service lines. So Tina, what haven't we hit that you think would be really interesting to see in the next 5 years on the clinical side?
Well, I think short term, I'm going to call it a violent agreement with what John just said, in that a lot of this is centering around low hanging fruit. And in our country, because of how the way we finance healthcare really drives probably a lot of where we focus, this is all around cutting the fat, making things more efficient, capturing more things so that we can be a little bit more on the pulse when it comes to billing, but then also reimbursement. But it has, and I hate to take this pessimistic view, but I will for a moment, it has a wonderful side effect of increasing access, which John really highlighted. So we're starting to get to the positive mission side of the house. So I think we're going to spend the next 2 years really doing bread and butter. And that's like my hope, because if we don't do that, you can come up with shiny new objects, but you have a burnt out healthcare workforce. You have over 50% of burnout in nurses, same in doctors. We don't even know for some of the other specialties, thinking about pharmacists and so on. But when you have a workforce that is already stretched, even if it is something good, they won't be able to imbibe it and use it. So, we just actually wrote up a white paper that we hope will get published soon that's setting the standard on how do you prove that your technology actually reduces load and friction for the end user? Whether it's, in this case, we're targeting clinicians, but I think it's appropriate for patients too, and we need to do that. After we get to that step, I feel like we need to march towards this horizon of like humanism in medicine. And how can we do that? So my hope is that at the same time we're advancing towards that horizon, we really are leaning into value-based care, which we've been saving for years and it's never actually happened. So if I could also envision a world in which the financial incentives are aligned a slightly different way, what would humanistic care actually look like?
Yeah. Alongside government reform that rewards good, quality, empathetic care, right?
Yeah. So I want to see AI applications that are doubling down on preventive care.
Yes.
And, and we're thinking about how, and I'm thinking about ARPA-H and some of the projects they have going on, but rural America, there's like a program manager that has a hairy project who's trying to bring really, really high acuity care down to rural America. Could you imagine an easy button and all of a sudden you can operate a CT scan? That's what we need. Yeah. So we really need to double down on preventative care. And then can we use AI to make technology so simple that we can put it in the hands of people that aren't even trained?
Amazing. The rural and the sort of like emerging regions, globally, that kind of application to increase access, increase the ability to actually treat and diagnose remotely. All of that stuff is fascinating for use cases. So we only have a couple more minutes left. I just want to pluck a couple things out that John said and kind of end with a little bit more of some sophisticated vocabulary we might need to break down. So this whole concept of point solution versus platform. In the early days of cloud, we were looking at cloud and infrastructure vendors, but no one was like sort of really dealing with cloud ops tooling. How do you go from on-prem to cloud? What's the tooling needed? Everything from migration to sort of, all the compliance and regulatory stuff around privacy using cloud and maintaining separate, sort of multi-tenant structures. So there's whole industry grew up around cloud that would be cloud ops. My sense is that, no one is really attacking the LLM ops space right now, that sort of platform level. How do you think about data migration? How do you think about using any foundation model and then thinking about bringing your own data and fine tuning governance, all of that stuff. So I feel like we're just in the early innings. And when you guys say we own our full tech stack or the health systems don't want point of solutions, there's all the hyperscalers. I mean, I was paid big bucks and I'm sitting here in Laguna Beach because of it. I do think that like Google and Amazon are going to be doing great tooling. And I think even Epic will lean in a little bit on some tooling in Gen AI. But, from my experience in working in both of those companies, they are not healthcare companies. They will have a vertical and some of the services in that vertical will be really applicable, but they don't understand change management. They don't understand, how healthcare is paid and just the sort of clinical culture of it. And so I think there is room for this sort of a lot of startups and a lot of what I would call sort of picks and shovels, in the LLM ops space, particularly for healthcare. So, given that you're actually incubating companies, John and Tina, you own your own tech stack. Where are you guys on that sort of platform versus point solution and the future?
It's a great question. We've been approaching the way I define platform is a little bit different in that we try to think about applications that can be verticalized and that are killer use cases, but developing a technology stack that is extensible to other kind of adjacent potential applications. And so that's how we've approached building Hume, building Care, building Ascertain, et cetera. I agree with you, though. There's a huge opportunity to build developer toolkits, picks and shovels, LLM tooling, et cetera. The biggest thing I struggle with when I look at it from an investment standpoint is I do think the hyperscalers are going to lean heavily into that space. And every major health system has, large health system at least, has multi-$100 million cloud commits that they need to draw down.
Right.
And many struggle to draw them down and have excess cloud commit they can't retire at the end of the year. And so I think health systems are always going to look to their cloud partner for that. And for a startup to beat out whatever the hyperscaler of choice is providing, it needs to be dramatically better. And so something we have a lot of conversations about internally are what are the places where startups can beat the hyperscaler? because the hyperscalers probably they're already working with the health system. They can integrate it better. They're better resourced, et cetera. And so we often try to look at places where hyperscalers, as you know, Missy, often get to 90%. They're producing things that are less customizable, less flexible, et cetera. And so we try to focus in areas where having an extreme level of accuracy,
Yes.
focusing on change management, things that are harder for hyperscalers to do, things that are less horizontal, for example, and where you really do need to go in, co-develop alongside with clinicians, iterate, pivot, focus on feedback, et cetera. We think those are the places where startups have the ability to win. And I hope that you see some startups in those LLM toolkits, because I think they'd probably end up being better. But I would probably bet on the hyperscalers right now, just based on everything I've seen.
Yeah, Tina, I think you guys probably have relationships with, all the hyperscalers, including NVIDIA. So where are you on that?
Yeah, that's right. I guess what I would say is this is about trying to pick the best partners. And you mentioned NVIDIA. They are actually one of our investors. So this is betting together. And I think this is a scenario in which 1 + 1 = 4 if you choose the right partner.
Yep.
So that's been our approach. But I almost want to go back to what John said about his definition of platform. And that really resonates with us, because what we don't want to do is come up with a great solution, but it's in a vacuum. And we will get into that 2024 problem of death by 1,000 point solutions, as opposed to death by, other things that we've coined before. So I think this is about looking at AI as a platform that's almost like the interface between clinician or patient and what currently is right now. So is it like, at the very least, can it curate everything for the patient, so that the patient doesn't have to jump around and call 5 different offices and get hung up by the MRI scheduler, 5 times? Like that, can we just curate everything? And like, if you think about it as a platform, we will have that ability. So I'm like also marking this, and you can tell I'm a former Fed like you, Missy, because I'm thinking about what the federal government's really trying to push interoperability, and they just came out with some very interesting stuff trying to maybe put payers and others around.
Yep.
So I think all roads are leading towards platform, and it's your loss if you're an innovator right now and you're thinking point solution.
Yeah, I love, John, I think that was a nice sort of redefinition of sort of the extensibility, starting with one application and being able to extend over. I am just looking at our time. I'm so wanting this conversation to continue. I just am loving what I'm hearing, and I'm getting so educated. We'll definitely have to have each of you back. What an absolute pleasure. Congrats on both of your success. And Tina, thank goodness that you were able to join Abridge, and I think just having someone with your background and your like the clinical practicalities of where you've been and what you're doing, it just makes it so much easier to understand. And John, I so look forward to see where you continue to innovate and place your dollars. It's been fascinating to watch you, and just very excited for your success. So thanks to both of you, and thank you everybody for listening.